Welcome to Section 7 of Cardiology. In this section, I will be discussing pressure tracings and jugular venous pulse. Let's get started. This is figure 2.10 from your text, which shows the normal changes in pressure that occur in the left atrium, the left ventricle, and the aorta during a single cardiac cycle. Notice that the y-axis is pressure, measured in millimeters of mercury, and the x-axis is time. Also note that this region here represents systole, and this represents diastole. Before I explain this figure in any more detail, why don't I take a step back and draw out a heart on a blank screen so we can better visualize what's happening here. On the left we have figure 2.10, and on the right we have a drawing of a heart. As we follow the heart through a normal cardiac cycle, we'll be focusing on the left atrium, the left ventricle, and the aorta. Recall that near the end of diastole, the left ventricle is filling with blood and the aortic valve is closed. So draw a closed aortic valve here. Also remember that the mitral valve, right here, is open. Just after the mitral valve closes, draw that right here, the heart contracts in an attempt to push blood from the left ventricle into the aorta. So this represents the left ventricle contracting. It's important to know that on the pressure tracing figure that the mitral valve closes here. We can see the green line, which represents the left ventricle, begins to rise just after the mitral valve closes. This makes sense. This is when the left ventricle begins to contract. As the space in the ventricle decreases, the pressure goes up, which is why we see the green line rise on the pressure tracing figure. Notice that the pressure in the aorta is much higher than the pressure in the left ventricle when the left ventricle first begins to contract. Eventually, the pressure in the left ventricle becomes greater than the pressure in the aorta, causing the aortic valve to open. So I'll erase the aortic valve on the heart image. Notice on the pressure tracing figure that this occurs right here. So aortic valve opens. So at this point, blood begins to move from the left ventricle into the aorta. Notice on the pressure tracing figure that the pressure continues to rise in the left ventricle. And this is because the left ventricle is continuing to contract throughout this point in time. Also notice that the pressure is rising in the aorta, the dotted blue line, and this is because the increased volume of blood entering the aorta exerts more pressure on the aortic walls. Eventually, the left ventricle finishes contracting and begins to relax. So I'll erase these red arrows representing contraction of the left ventricle. Draw new arrows showing that the left ventricle is relaxing. As this happens, we can see on the pressure tracing figure that the pressure in the left ventricle begins to fall. As the pressure in the left ventricle falls below the pressure in the aorta, the aortic valve closes. So I'll erase this arrow, show the aortic valve closing again. On the pressure tracing figure, this represents closure of the aortic valve. Notice how the pressure in the aorta slightly decreases and then increases at this point. This is called the dicrotic notch and occurs because blood is no longer moving from the aorta into the left ventricle. Because the aorta is no longer losing blood to the left ventricle, the pressure is allowed to slightly rise, as we can see here. Also notice how the pressure in the aorta continues to drop during diastole. This occurs because blood is moving from the aorta throughout the systemic circulation. So as the left ventricle continues to relax, the space in the left ventricle increases, which means the left ventricular pressure decreases. Notice how during systole, the pressure in the left atrium is slightly increasing. This occurs because the pulmonary veins are emptying into the left atrium, so the volume in the left atrium is increasing. Eventually, the pressure in the left ventricle drops slightly below the pressure in the left atrium. It's at this point that the mitral valve opens. So on the image on the right, we'll erase mitral valve closed. The slight difference in pressure here allows blood from the left atrium to enter the left ventricle. The process then starts all over again. Okay, with this in mind, let's see what your text says. Pressure tracings are a way to graphically measure the pressures in the left atrium, the left ventricle, and the aorta during a single cardiac cycle. And they can be used to examine valvular abnormalities, which we'll get into more in a minute. Now that we've covered a normal pressure tracing, let's go through a few examples. Okay, the first question is, how would the pressure tracing figure change in a patient with mitral regurgitation? Before I answer this question, let's add a picture of the heart and briefly review mitral regurgitation. Recall that mitral regurgitation occurs when the mitral valve is damaged such that it doesn't close properly during systole. So normally when the left ventricle contracts, which I'll indicate with these arrows here, the mitral valve should be closed. So I'll draw on a closed mitral valve. This allows blood to move smoothly from the left ventricle into the aorta. However, patients with mitral regurgitation have an abnormal mitral valve, which means blood can move from the left ventricle into the left atrium during systole. So blood is able to get past the mitral valve and move into the left atrium. This means blood can move into the aorta and the left atrium during systole. That means in patients with mitral regurgitation, we'd expect there to be excess volume in the left atrium during systole. So increased volume. Okay, so with this in mind, let's return to the question. How would the pressure tracing figure change in a patient with mitral regurgitation? Well, we just learned that during mitral regurgitation, excess blood ends up in the right atrium during systole. If there's increased blood in the right atrium, then we'd also expect the pressure in the right atrium to be abnormally elevated. And that's exactly what happens. Instead of the left atrial pressure line staying relatively constant during systole, it increases. So I'll draw that here. As the left ventricle relaxes, eventually the pressure in the left ventricle is less than the pressure in the left atrium. As we can see, the pressure in the left atrium is abnormally high during systole for the reasons I just explained. So you can see the pressure is high during this period. As the left ventricle relaxes, so I'll erase these arrows, show that the left ventricle is relaxing. Eventually the pressure in the left ventricle becomes less than the pressure in the left atrium, which we can see here on the pressure tracing figure. At this point, blood is no longer abnormally moving from the left ventricle into the left atrium due to the changes in pressure. So I'll erase this green arrow showing blood moving from the left ventricle to the left atrium. Rather, the direction of blood is reversed, which means blood now moves from the left atrium to the left ventricle. As the excess blood re-enters the left ventricle, the pressure in the left atrium experiences a sudden drop, which we can see right here. Okay, let's do another question. How would the pressure tracing figure change in a patient with mitral stenosis? Let's again add a picture of the heart and briefly review mitral stenosis. Recall that mitral stenosis occurs when the mitral valve is damaged. I'll represent that here with a narrow opening between the left atrium and the left ventricle. And this makes it harder for blood to pass from the left atrium to the left ventricle. Because it's harder for blood to move from the left atrium to the left ventricle, there is more blood in the left atrium during diastole and during systole. This means we'd expect the pressure in the left atrium to be higher than normal. So we'll just draw an up arrow with a P to represent increased pressure. Okay, so with this in mind, let's return to the question. How would the pressure tracing figure change in a patient with mitral stenosis? Well, if the pressure is higher in the left atrium, then we'd expect the pressure tracing to look something like this. Notice on our figure that the pressure was originally here in the left atrium, and it's been shifted up higher to right there. During diastole, the stenotic mitral valve is open, so blood is moving from the left atrium to the left ventricle. Again, I'll draw this arrow in, showing blood moving from the left atrium to the left ventricle. Because the volume in the left atrium is decreasing during early diastole, we'd expect the pressure to decrease, which I'll draw here. Notice here, a little bit later during diastole, that the pressure begins to rise. So why is the pressure in the left atrium increasing during late diastole? It's because this is when the left atrium contracts. So I'll draw on these arrows representing the left atrium contracting. Remember, the left ventricle passively fills during early diastole and then actively fills during late diastole as the atria contract. Because the left atrium is contracting against a stenotic valve, it experiences a sudden increase in pressure, which we can see on the pressure tracing figure here. As the left atrium relaxes, the pressure in the left atrium decreases. So I'll erase this. I'll show that the left atrium is relaxing, causes a decrease in pressure. On our figure on the left, we can see that this is occurring right here, the downward slope. Also notice that right here, the mitral valve closes. I'll draw that on our image over here as well. Just after mitral valve closure, the left ventricle begins to contract and blood moves normally through the aorta, so the rest of the figure appears normal. Here's another pertinent question while we're on the topic. Do you remember what microbe is most commonly associated with this pressure tracing of mitral stenosis? Group A beta hemolytic streptococcus, or GAS. Remember that patients with group A strep commonly present with acute pharyngitis. If the infection goes untreated, then the patient can develop antibodies against the microbe, which can sometimes also attack the mitral valve. This is called rheumatic fever and most commonly affects the mitral valve, but can also affect the aortic and tricuspid valves less frequently. It's really important to remember that early on in the disease, the mitral valve becomes leaky, so you'd expect patients to have mitral regurgitation. So early, patients get mitral regurgitation, MR for short. However, late in the disease, the mitral valve becomes stenotic, so you'd expect patients to have mitral stenosis. So late MS, mitral stenosis. So remember, if you ever get asked about a pressure tracing in the context of rheumatic fever, pay close attention to whether the disease is acute or chronic. Okay, let's do another question. How would the pressure tracing figure change in a patient with aortic regurgitation? Let's again add a picture of the heart and briefly review aortic regurgitation. Recall that aortic regurgitation occurs when the aortic valve doesn't close properly during diastole, which means blood leaks back from the aorta into the left ventricle. Because blood is lost from the aorta during diastole, we'd expect the pressure in the aorta to decrease during diastole. So write decreased P for pressure. So the aortic pressure tracing would look something like this. We'd also expect the excess blood in the left ventricle to cause the left ventricular pressure to rise during diastole. Increased pressure in the left ventricle. So the left ventricular pressure tracing would look something like this. During systole, the pressures are mostly unchanged because blood is moving from the left ventricle into the aorta as normal. So if we look at this region, we can see that the pressures look relatively normal. Because the mitral valve is unaffected, we'd expect the left atrial pressure to be normal. So now that you can see the new pressure tracing, during what part of this figure do you think you'd be able to hear the regurgitant murmur if you placed a stethoscope on the patient's left sternal border? Well, aortic regurgitation occurs during diastole. Normally, the aortic valve closes here, and this marks the beginning of diastole. However, in patients with aortic regurgitation, it doesn't close properly, which is why the pressure in the aorta drops more rapidly. So if you know the pressure is dropping here, because blood is moving from the aorta to the left ventricle, then you can deduce that the murmur would be audible from here to here. In other words, the murmur occurs all throughout diastole. Here's another question related to aortic regurgitation while we're on the topic. Why does head bobbing occur in patients with aortic regurgitation? Well, in aortic regurgitation, blood leaks from the aorta back into the left ventricle, which increases the preload on the heart. The increased preload results in an increased stroke volume. So the increased volume of blood leaving the heart enters the carotid arteries, and the transfer of this momentum from the heart to the carotids causes the head to bob. So if you were to palpate the carotid arteries in these patients, then you could feel a brisk upstroke and downstroke of blood flowing through the carotid arteries. Okay, moving on to aortic stenosis. How would the pressure tracing figure change in a patient with aortic stenosis? Let's again add a picture of the heart and briefly review aortic stenosis. Recall that aortic stenosis occurs when the aortic valve is damaged. So I'll draw in a thick aortic valve. This makes it harder for blood to pass from the left ventricle into the aorta during systole. Remember, the pressure in the left ventricle continues to rise until the aortic valve opens. If the aortic valve is stenotic, then the pressure in the left ventricle has to increase even more in order to open the aortic valve and allow blood to move from the left ventricle into the aorta. So there's increased pressure in the left ventricle. We know that this is occurring during systole, so with this in mind, we can draw in a new pressure tracing of the left ventricle, which would look something like this. Notice how the pressure in the left ventricle is much higher than normal during systole. Because the mitral valve is unaffected, we expect the pressure in the left atrium to be unchanged. So we have a normal left atrium pressure tracing. Pressures in the aorta also remain unchanged because a similar volume of blood is still in the aorta during systole and diastole. So our aorta pressure tracing will also be normal. Okay, let's do another example. When would blood flow through the coronary arteries be the highest in our pressure tracing figure? Recall that the left and right coronary arteries arise from the root of the aorta near the aortic valve. So draw on the coronary arteries right here. Recall that the aortic valve is actually somewhere around here. As the heart is contracting during systole, the aortic valve is open and blood is moving past the coronary arteries into the systemic circulation. As the heart relaxes during diastole, the aortic valve closes. It's at this point that blood gets pulled back against the aortic valve and easily flows into the coronary arteries. Okay, with this in mind, let's also recall the blood flow equation from section 2, which is blood flow equals the pressure gradient over resistance. From this equation, we can see that the flow is highest when the pressure gradient is high. It's also high when the resistance is low. Remember from before that the aortic valve closes here. Just after this, the pressure in the aorta is high. At this point, the pressure in the coronary arteries is low because they've been emptying into the coronary sinus throughout the end of diastole and during systole. So in summary, the blood flow through the coronary arteries is greatest at this point because this is when the pressure is high in the aorta and low in the coronary arteries. From this equation, we can deduce that if the pressure gradient is high, then the blood flow through the coronary arteries will be high. Okay, moving on to jugular venous pulse, or JVP. A jugular venous pulse waveform can be obtained by placing a central line into the internal jugular vein. So I'll draw in a little bit more on our heart image. This will represent the internal jugular vein, and then the superior vena cava and the right atrium. We can feed a central line through the IJ, down through the superior vena cava, and into the right atrium. Usually the tip of the central line is resting near the SVC, and it allows us to measure changes in pressure that occur in this region. These pressure changes produce a waveform which is known as the jugular venous pulse, or JVP. So you can see that anything that causes the pressure to increase near the central line will produce a positive slope in the waveform, and anything that causes the pressure to decrease near the central line will produce a negative slope in the waveform. Let's look at a normal JVP waveform now. So again, on the left we have an image of the jugular venous pulse waveform, and on the right we have an image of the heart. The y-axis of the waveform measures pressure, P for short, and the x-axis measures time. When the right atrium contracts, which I'll draw with these arrows, the space in the region near the central line decreases, so the pressure increases. The increase in pressure is detected and is responsible for the upward slope we see here, known as the A wave. Some students use the letter A to remember that it's here that the right atrium contracts. So A for atrial contraction. The right atrium then relaxes, so the pressure decreases. This is responsible for the downward slope we see here. At this point, the tricuspid valve closes, which I'll draw right here. So blood begins to build up in the right atrium. And this causes the pressure to slightly increase. This is responsible for the upward slope here, known as the C wave. Some students use the letter C to remember that it's here that the tricuspid valve closes. So C for close. After the tricuspid valve closes, the right atrium continues to relax. So even though blood is pooling in the right atrium, the increased relaxation of the right atrium causes the pressure to continue to decrease. So this deep valley in the waveform is called the X wave, and this is caused by atrial relaxation. Some students use the letter X to remember that it's here that the right atrium relaxes. So X for relax. You can see that the slope begins to move upward again here, and this is because the body has had more time to fill the right atrium with blood. So blood presses against the walls of the right atrium, causing the pressure to increase, and is responsible for the V wave here. Some students use the letter V to remember that it's here that the right atrium is filling with blood. So V for villing, or filling with blood. At this point, the tricuspid valve opens. So on our JVP waveform, that occurs here. Tricuspid valve opens. Again, remember that it's right here that the tricuspid valve closes. So when the tricuspid valve opens, this causes the pressure in the right atrium to decrease because blood is moving from the right atrium to the right ventricle, which is responsible for the downward slope on the waveform, which we see here. This valley in the waveform is called the Y wave. Some students use the letter Y to remember that it's here that the right atrium is emptying. So Y in the word emptying. Finally, the process starts over again, and we can see another A wave beginning to form here. Okay, with this background, let's see what your text says. So the jugular venous pulse is measured by placing the tip of a central line near the right atrium. This allows us to detect changes in pressure, and it produces a waveform, which is known as the JVP. So increases in pressure cause positive slopes on the waveform, and decreases in pressure cause negative slopes on the waveform. So with this in mind, let's do a few examples. How would pulmonary hypertension alter the JVP waveform? Recall that pulmonary hypertension can occur when the pulmonary vasculature becomes thick and narrow. This can occur for many reasons, which I'm not going to get into now, but when it does occur, it makes it harder for the right ventricle to pump blood into the pulmonary circulation. Eventually, the right heart becomes hypertrophied, which decreases the space in the right side of the heart, causing right-sided heart pressures to rise. So, pulmonary hypertension can cause hypertrophy of the right side of the heart, which causes an increase in pressure. The decrease in space on the right side of the heart also causes an increase in resistance, making it harder for blood to move from the right atrium to the right ventricle. So, increased resistance. The increased pressure and resistance cause the pressure in the right atrium to rise more than usual during atrial contraction. So the A wave will look something like this. The Y wave is also affected and would look something like this. This is because blood has a harder time emptying from the right atrium into the right ventricle when the pressure and resistance on the right side of the heart have been increased. Can you think of anything else that may cause an A wave to be higher than normal? Third-degree heart block. Recall that in third-degree heart block, the atria and ventricles are desynchronized and are beating independently of one another. This means that the right atrium may be contracting against a closed tricuspid valve, causing the pressure in the right atrium to increase dramatically. When this happens, we can see what are called cannon A waves, which would look something like this. Just very large A waves. Okay, let's do another question. How would atrial fibrillation alter the jugular venous pulse waveform? Recall that atrial fibrillation is a result of abnormal electrical signals that disrupt the SA node, which causes electrical remodeling. This causes the atria to beat so fast that it begins to look more like the atria are rapidly twitching rather than contracting. The lack of normal atrial contraction results in an absent A wave. So we'd expect the JVP waveform to look something like this. This makes sense. The A wave normally occurs when the right atrium contracts, so if the right atrium cannot contract, then we'd expect the A wave to be absent. Recall that the right atrium is also unable to relax properly, so we'd expect the X wave to be abnormal and look something like this. Remember, the X wave is when the atria is relaxing. If the right atrium can't relax, then the pressure doesn't decrease, which means the X wave will look something like what I've drawn right here. So again, an abnormal A wave in atrial fibrillation and an abnormal X wave. Okay, let's wrap this section up with one more example. How would tricuspid regurgitation alter the JVP waveform? Recall that tricuspid regurgitation occurs when blood abnormally moves from the right ventricle to the right atrium during systole. On the JVP waveform, the C wave represents closure of the tricuspid valve, and the X wave represents atrial relaxation. However, the tricuspid valve isn't closed tightly, so blood is able to move from the right ventricle into the right atrium, and the excess blood causes the pressure to increase rather than decrease, which means the X wave will look something like this. Eventually, the tricuspid valve opens and blood is able to move from the right atrium into the right ventricle, so the Y wave would just look normal. While we're on the topic, do you remember any commonly tested causes of tricuspid regurgitation? IV drug abuse and Staph aureus. That concludes this section.